everyone. Can you hear me clearly? Okay. So the first scenario of today is about this patient who is in a correctional facility. So the question: during a visit to a correctional facility, you evaluate several inmates. One particular inmate has a history of methamphetamine use and was previously a smoker. However, due to the prison's no smoking policy, he is now using nicotine replacement patches. Clinical examination reveals poor oral hygiene and photographs show light brown cervical caries affecting most of his upper anterior teeth. So what is the role of methamphetamine to cause his pattern of caries? So is it because of craving for sugary drinks or poor oral hygiene? Craving for sugary drinks. This specific patient or patients who are addict to methamphetamine are usually craving for sugary drinks, right? Poor oral hygiene can come second, but the first option here, the first answer should be craving for sugary drinks. So it is multifactorial, honestly speaking, and they already mentioned that the patient is having a problem regarding the hygiene. You can see here clinical examination reveals poor oral hygiene, but the main issue here that the patient is craving for sugary drinks. Okay, when should we go for alcohol abuse? When should we go? Generally speaking, when should we go for alcohol abuse? Erosion signs. Very good, Dr. Babita. That's my point. Very good. Okay. So usually the pattern of methamphetamine, how it looks like, which surfaces are mostly affected? You remember this question? Cervical and interproximal and buccal. If you have to choose between cervical interproximal and cervical and buccal or interproximal and buccal, what would you go for? Cervical and interproximal mostly. Yes. Methamphetamine, also called ice, crystal meth, glass, shards, or puff. This drug causes severe tooth decay in a very short time. The term meth mouth is used to describe the extensive damage typically caused by this drug. It is highly acidic and attacks the tooth enamel. It may cause dry mouth, teeth grinding, which is bruxism, jaw clenching. Many illicit drugs cause dry mouth, and combined with cariogenic diet and a lack of oral hygiene can result in dental caries. Okay? So as I mentioned before, that lack of oral hygiene also is a great factor. However, if we have to choose between them, we would go for craving for sugary diet or drinks. Is my point clear so far? On examination, you found 5 mm pocket depth and slight gingival inflammation. What do you think is masking the periodontal disease? We discussed this question before. Do you remember? So there is generalized suppression. Usually, when the patient is smoking and the patient already due to the policy of the prison has just stopped or already stopped smoking. Okay, so it's not logic enough to go for decreased blood circulation of the gingiva due to smoking, but rather because of the generalized suppression of decreased blood circulation in the gingiva due to methamphetamine use. When you administered, and it would, listen carefully please, it would be affecting the whole body. I mean methamphetamine would be affecting or suppressing the whole body, maybe for few or many years. Okay, so it's not directly the effects or the long-standing effects of methamphetamine will not be withdrawn immediately, no, but it may stand for so many years. Is this point clear? It's given in one of the references, by the way. When you administered local anesthesia, he has slight palpitations which result in few seconds. What do you think is the reason? As you know, this is the effect of adrenaline, which is in the local anesthesia cartridge. The next SPQ is about effucation radiolucency circled on the OPG, and they ask what is the clinical description. So it's intraradicular bone loss. It's clear on the OPG, which was given in the exam as per people who seated that exam. BPE mostly 4 and 3. What is the appropriate management? We have only one option here. So what do you think about the appropriate management? Generally, when it's 4 and 3, what should we do? So we would do 6-point charting and probing tips for all teeth, because this may be requiring comprehensive periodontal assessment. Yeah, reassessment, probing depth, all the teeth, referral to a specialist may be needed. So perio charting. As you can see, and this is given in different sites in this file, how to use PPE. All new patients should have the BPE recorded. For patients with codes 012, BPE should be recorded at every routine examination. Can you see? Can you see? For patients with BPE codes of 3 or 4, a more detailed periodontal charting is required. Code 3, initial therapy, including self-care, advice, oral hygiene instruction, risk factor control. Then post initial therapy, record a 6-point pocket chart in that sextant only. If there is code 4 in any sextant, then record a 6-point pocket chart throughout the entire dentition. Can you see? That's why we opted for that option. Okay, pay attention please. Pay attention please. We have only one option here, right? We have only one option. So we have at least other 3 options. So I believe it's important here, important point, because if you are just copying, pasting this answer, you have a real problem when you answer this question in the exam. Why? Because they mention BPE mostly 4 and 3. So there may be some further information, like in one of the sextants, the PPE is 3. So what would you do? What would you do? Hopefully you got me right. So you would do 6 point. Yes, that's correct, Dr. Ishani. You do 6 point pocket chart in that extent only, right? And what if you found that there is in one sextant, if you found in one sextant code 4 in any of the sextants, what would you do? That is important, guys. Yes, exactly. 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 Who can sum up what I just said or what you understand from this point? Who can sum up? Somebody should sum up right now, please. Yes, code 3, then 6 point chart in that particular sextant only. And in case there is PPE of 4 at any of the sextants, we would do for the entire dentition. Is this clear? So please pay attention to these points. For patients who have undergone initial therapy of periodontitis and who are now in the maintenance phase of care, then full periodontal depth throughout the entire dentition should be recorded at least annually. Important. In addition, it's recommended that BPE should not be used around implants. 4 to 6 point pocketing charting should be used. Radiographs should be available for all code 3 and 4 sextants. The type of radiograph is used a matter of clinical judgment, but crystal levels should be visible. Many clinicians would regard periapical view as essential for code 4 to allow assessment of bone loss as a percentage of root length and visualization of periapical tissues. This is another important point. Okay? Okay. An old man came because of dental pain. There was a photograph showing a lot of calculus spaces between teeth, recessions. He took warfarin. There is irreversible pulpitis in tooth 1-6. You decided that you extract the tooth. There was a chart where PPE was 3 to 4. Recession, not resection. As I mentioned, people sometimes are amazing after the exam. Spelling and many other things, many problems. Recession 1 to 2 mm. Some furcation involvement, few missing teeth. What was the general perio status? So the stage is stage 2 generalized periodontitis, right? Why it is stage 2, guys? Why it is stage 2? Why it's generalized periodontitis? PPE as 3 to 4, which means moderate, right? And why it's generalized periodontitis? because you can see that there is recession, there is a lot of calculus, right, is affecting different teeth. There are also furcation involvement. There are few missing teeth, of course, thanks to periodontal disease, even if they didn't mention so, but according to the general picture, you would expect that these few missing teeth would be thanks to periodontal disease. Yeah, there are some information which is lacking. However, you can concluding that from the general information given. You know that recession was 3 and the pocket was 4 mm. So 3 mm recession and pocket is measuring 4 mm. So what is the CAL? Clinical attachment loss. So you would just 3 plus 4, it would be measuring 7, right? And that is 7. Yeah, recession plus probing depth. Very good, Dr. Ishani. You made an initial perio treatment after 1 month. What kind of reduction of pockets you might see? This is from Karanza. 1 to 2 mm. What is the important factor in hygiene along with interdental brushes? A or B, guys? Are you sure? It's A. If we're asking about most important, so you here opted for just for the one marked. What do you think? They mentioned interdental brush. Okay, let's go over this one. They didn't mention here. Yeah, of course. Of what important factor in hygiene along with interdental brushes? Because they already have or they are using interdental brushes. So flossing of no use here, right? You think so? Yes, perfect. So chlorhexidine or chlorhexidine mouthwash here would be important factor along with interdental brushes. Very good job. So in case they didn't mention interdental brushes for general patients or in different cases, flossing is more important than medications. Medications are of course important, like some medications which are working on anaerobic bacteria. However, it's not just sufficient for treating periodontitis. Flossing is extremely important. But here, as you mentioned, this is the patient is using interdental brushes, so chlorhexidine mouthwash would be important here. Okay? Yeah, plus increased spaces between teeth, so interdental brushes is good. Yeah. You knew that you will extract the tooth next appointment. His INR was 3. What medication you prescribed to him knowing that the pain was severe, apart from paracetamol? So this patient is taking warfarin. Okay. So the patient INR and the severe pain, a small dose of oxycodone would be appropriate. Right? We cannot prescribe non-steroidal for this patient because it would be interacting with warfarin. There would be increased bleeding ability. So for elderly people. Assess the need for non-steroidal in elderly people particularly carefully. Elderly people are generally at increased risk of renal and cardiovascular and gastrointestinal adverse effects of non-steroidal. Elderly people are also more likely to have comorbidities and take other drugs, what we call it polypharmacy, that increase their risk of non-steroidal related adverse effects. If a decision is taken to use non-steroidal in an elderly patient, non-steroidal with a short life are preferred. Like what, guys? What short life? Like what? It may be a question in the exam, by the way. Like what? Dr. Ishani mentioned ibuprofen. What do you think? Aspirin, others of non-steroidal, what do you think? Dr. Imelda said ibuprofen. Dr. Siri the same. Who would say something different? Low dose of ibuprofen. Very good. I like this detailed answer. Ibuprofen has short life compared to naproxen or Kilcoxib, right? How about aspirin? Aspirin is non-steroidal, correct? Aspirin is non-steroidal. Am I correct? But it's increasing bleeding. Yeah. Guys, aspirin, I know it's antiplatelet. Is it non-steroidal, yes or no? Yes, it is. But we can't give it here, right? That's the point. So it's better to go for non-steroidal, which is having half short life, like ibuprofen. Next visit, he came with his daughter, and she told you that they had to resign from treatment because of financial constraints. What did you do, or what do you do? I think this patient is elderly and he is or she is a pensioner, right? Okay. Yes, we can suggest payment plan talking with the daughter. A is correct, but also D is correct. So I believe myself, okay? I believe myself A or D would be correct, both. And mostly this question would be unscored. But if we have to give a priority, what should we go for? If we are going to give priority. Yeah, very good, Dr. Bennett. You mentioned that it is emergency and it's irreversible pulpitis, correct? So you can deal with irreversible pulpitis by just referring the patient to public hospital. I don't think this is a good idea when we are giving priorities, right? Elderly people has priority in public health, but still, I see the same, right? I would suggest payment plan because this patient is having now severe pain. Dr. Ahmed, he has now severe pain. So first of all, I would suggest payment plan for this patient. And then if the patient is still, or the daughters is still saying the same, we can't even go for a payment plan, then you would suggest referring to public hospital. Is this clear? So A comes before D. However, I believe both are correct from the other side. An old man around 70 years old came saying that he just wanted to do cleaning. There has a lot of carious lesions. He had hypertension, took medications but didn't check his health a few years ago. When you started to talk with him, he told you that he took medications of his wife due to the same color and size. He has poor oral hygiene. What do you do? So in patients who is having hypertension and did not check the hypertension for a while, okay, he's taking his medications but did not check the hypertension for a while. So as a general rule, you would go for non-invasive treatment and you wait until checking his hypertension. So what non-invasive treatment looks like? Like what? You may have some details regarding this option. You may not have the same option, but some details. Like what? Scaling, right? What's else? This patient is having a lot of carious lesions. So what would you do? Restorations, yes. Oral examination, all are correct. Scaling, x-rays. These are not all invasive investigations or treatment, right? But oral examination it's just not treatment. It's diagnosis or for diagnosis. It's a step for diagnosis. So they are asking about treatment here, okay? X-rays is a part of diagnosis. We have to be careful, okay? When they ask about the treatment, then we would go for treatment. When they ask about management, it's a different story. Management is including the or maybe including diagnostic steps. So do non-invasive treatment like restoration, scaling, and of course not surgery, okay? Surgery would be invasive. He had a lot of cervical caries. What is the best material which can be used here? So resin modified GIC is preferred for cervical carious lesions due to its fluoride release, the chemical adhesion to the tooth structure, and suitability for areas prone to moisture, right? And at the same time, it's aesthetically acceptable. However, as you know, in old ages, aesthetics usually are not of prime concern. So resin modified GIC is aesthetically acceptable. It's not perfect. 25-year-old patient came after trauma of tooth 2-1. There was bleeding from the sulcus around the tooth. The tooth was mobile without changed position. So the tooth was mobile without changed position. What does it mean? So mobile tooth without displacement means subluxation, right? You asked him when trauma was, what kind of information will give you the answer for that question? So why you ask the patient the question in another frame? Why you ask the patient about the timing of the trauma? To know the kind of prognosis, to know the prognosis of that tooth, right? Or to expect the prognosis of that tooth. What's your diagnosis? As you mentioned, it is subluxation. You gave him a splint for how long? In case of subluxation, they ask these questions many times in the exam, maybe in different papers. 2 weeks flexible splinting, right? In lateral luxation, palatal or labial, and there is alveolar fracture, what should it be? This is another question. 6 weeks. Thank you for people who paid attention last time. 6 weeks. Yes. So should be basically 2 weeks plus, or 4 weeks plus 2. So 4 weeks plus 2. It's given in international trauma guidelines to be 6 weeks. 4 plus 2. After that time, what kind odd symptom might have been a sign that there was bleeding? Yes, exactly. So persistent mobility after a period of splinting suggests healing hasn't occurred as expected and may indicate complications such as continued ligament damage or lack of proper stabilization. So mobility, because negative response to cold test, this may take place up to 1 or 2 years sometimes. In I think in Cameroon it's mentioned 1 year. A lady is living on a farm. She has 2 kids. The patient has many cervical lesions. You had to extract 4/6 and 4/7. She was afraid of infection. What advice you give her? Rinse, rinse 3 times a day with water with salt or saline. After on the day of extraction, no. Not on the day of extraction. It should be on the second day, right? Very good. How could you make caries risk assessment? So caries risk assessment basically, or the first step is analyzing the diet and dietary habits. Analysis of diet itself may be performed in a variety of ways. The patient can be asked to recall all foods consumed over the previous 24 hours. This is not very effective, relying as it does on a good memory, honesty, and is unlikely to give a representative account. Relying on memory recall events that occurred more than 24 hours ago is too inaccurate. The most effective method is for patients to keep a written record for their diet for 4 consecutive days, including 2 working days and 2 leisure days. This is given in Odell. What kind of denture would be best for hair just immediately after extraction? And this stands for acrylic denture or immediate denture, right? After 5 years she came, what will you do for her knowing that her old denture is loose and many cervical lesions of anterior teeth were there? Okay, suppose after 5 years, thanks to ridge resorption, the lady has now non-retentive denture. It's loose, okay? But moreover, it's fractured while she was eating. What would you do? What is the best option? right? You do a new acrylic denture. It's better to do a new acrylic denture, correct? But here it just needs relining, and that's it. She had many cervical caries lesions. What material is the best? Resin modified GIC. She wanted to stop smoking. How could you help her? What would you do? Set a date with her for that. The patient is already willing to quit smoking. Setting a quit date is a proven strategy in smoking cessation. Providing a clear goal, increasing the chances of success. The 5 A's: ask, advise, assess, assist, arrange. Recommend setting a quit date to empower the patient. The other options are not strong as setting a date. A patient with pain on the left upper side. There is diagnosis of irreversible pulpitis, mostly 2-7, and there was amalgam filling in 2-7, and underneath there was caries which is close or reached the pulp. You make a diagnosis that a 2-7 was the cause. Okay, what was the reason for this pain in 2-7? So as per the clinical picture we have here, that there is caries which has reached the pulp underneath the amalgam filling, correct? So simply it's recurrent caries. What is true according to or in regards of upper 7? The anatomy of 2-7 or upper 7. So the mesobuccal canals has two canals and just one foramen, right? Two canals and one foramen. You decided to go for RCT, but the patient did not want a rubber dam. He has a wedding in 2 days. What would you do? Should you go for B or D? B or D? So it's clearly they mentioned that the patient didn't want the rubber dam, right? So what would you do? So this question answer depends on the frame, on the scenario itself. First of all, you need to explain to the patient. So it sounds here that you explained and the patient didn't want the rubber dam. So it doesn't make any sense to repeat it again, that RCT without rubber dam, that you can do RCT without rubber dam, right? And here they mentioned RCT without rubber dam. You cannot do RCT without rubber dam. So you give another option to extract the tooth, right? An 18-year-old boy came complaining of his front teeth edges getting sharp. He has asthma and has been on asthma corticosteroid preventer occasional salbutamol inhaler on extirpation episodes. He prefers vegetarian diet. He likes to exercise cycling on weekends and plays football. Photo was given covering labial aspect of two upper central incisors, shiny labial surfaces with slight thinning on incisal edges. Lateral incisors not completely shown and no much of erosion visible. By the way, guys, I'm asking you a question out of the context. Basically, do you have an idea? Do you read about the vegetarian diet in general? Generally, what do you think about vegetarian diet? Some people who are living on vegetarian diet. Yes, very good, Dr. C. Vitamin B12 deficiency. Perfect. Yes. What's else? What's else? So those people are having real issue because some people iron too. That's correct. Some people think that vegetarian people are living the healthiest life ever. Do you think so? Do you think they live the healthiest lifestyle? Are you sure? Yes. Although all the of these vitamin deficiencies? No way. I don't think so. There are specific fats which are important for the brain. They are not given in the or even in the protein the vegetarian proteins. You understand me? They are given only in meats and stuff like this. There are specific fats are not given or present in vegetarian diet. So I myself, based on some evidence-based studies, I believe that they lack important nutrients. They are not given in the vegetarian diet. What is the cause of erosion? What is the cause of erosion here? So shiny labial surfaces. This means what? What do you think about the word shiny labial surfaces? There is external, yes, very good, Dr. Ishami. External surface resource of erosion. So I would go for salbutamol inhaler. Asthma medication, especially vapor inhalers or puffers, not only have low pH but also tend to relax smooth muscle of the gastrointestinal tract, leading to a possibility of acid reflux, which can compound the problem. So the primary issue here is salbutamol inhaler, and the secondary issue, that's why we should refer this patient for consultation to a GP. Can you see? And that is the next question. They didn't mention anything about sport drinks, I think. Nothing, okay? They give it as an option, right? But there is nothing about the sport drinks. They give sport drinks in another question, but not this one. Can you see here? This is from Mount and Hume. In case they give you salbutamol inhaler as occasional use and sport drinks, then we would go for sport drinks due to frequent use. So here the answer again, salbutamol inhaler, and according to Mount and Hume, these puffers have low pH and may also leading to a possibility of acid reflux, and this can compound the problem. So we can have this question. Listen, please. We can have this option a bit differently, like primary salbutamol inhaler and secondary, or maybe secondary acid reflux. This would be very correct option, right? But as they give in different options, we would go for salbutamol inhaler. Because of possibility of acid reflux here, how do you prevent further erosion? Preventing further erosion should be, according to, what do you think? What's best here? You would go for asking him to wash the mouth after inhaling or consulting his GP regarding possibility of acid reflux. Yeah, that's why I'm asking Dr. Carolus. You have a good point. What do you think, guys? You would go for 4, knowing that we opted for the previous question for salbutamol. How do you prevent further erosion? I'm just thinking with you. Yeah, consulting as overall management of the case. It's better to go for consultation as your first step here. So consulting his GP regarding the possibility of acid reflux. This should be, because this is maybe having a secondary issue of erosion, or maybe secondarily resulting in erosion, so it's important to consult his GP. And of course, asking him to wash the mouth after inhaling, this would be very correct. He feels dry mouth after practicing sport. How would you manage? Asking him to drink more water. Increasing water uptake helps keep the mouth hydrated and can mitigate the dry mouth sensation that might lead to further erosion. An early exfoliation of tooth A3 with clinical photographs from left, right, front side, there was definitely a midline shift to the right. What could have been done to avoid the midline shift? Do you remember this question, guys? You remember this question? We made our quotation from Cameron. So place banded loop. This is a unilateral loss of one of the molars, correct? What do you think? What would you do? You would extract 7-3 to balance 8-3, or you would place a band and loop around 4 and have arm seat on or rest on 8-2. What do you think? A or C? A or C? C. Okay. Fixed maintainers have the advantage that they are worn continuously and don't require patient cooperation in wearing them. It should be noted that the placement of fixed appliance in a child at high risk may compromise those teeth which are banded as well as adjacent teeth. Band and loop appliance is typically used in cases of unilateral loss, and here they mentioned as early exfoliation. And we mentioned before that balanced extraction should not be your first option, right? Unless there are specific indications. Do you remember the indications, guys? Like yes, badly decayed tooth, a tooth which cannot be restored on the other side. So there are specific indications in which we can go for balanced extraction. But here, this is not the case. So it's preferable as long as there is early exfoliation of 8-3. It's not the timing for exfoliation. Then it's better to go for placement of band loop around 8-4 and have arm rest on 8-2. So band and loop appliance is typically used in cases of unilateral loss. Distal show appliances are used when second primary molar has been extracted before the eruption of first permanent molar. This is the indication for distal show, okay? A transpalatal arch is used in maxilla. A lingual arch is used in the mandible. Nance appliance or lingual arch can be used if the loss is bilateral. Is this clear? The next SPQ. A patient came with complaint of front teeth getting darker in color. The patient tells you that she had got RCT done on one front tooth 15 years ago. She didn't remember what tooth was it. What will be the most appropriate investigation to make the diagnosis? Most appropriate investigation. This 15 years ago, okay? Please pay attention. Suppose I'm asking you like what is the most appropriate investigation 1 month after trauma, after history of trauma? You would go for pulp sensibility, right? There's trauma and there is no RCT, so you'd go for pulp sensibility. Okay, suppose on the other hand, a patient who did not have RCT and they ask you what is the most appropriate investigation, no RCT, after 1 year. Still pulp sensibility, right? Very good. They are using, according to many or different Australian dental journals, they are using sensibility rather than sensitivity or vitality. Nowadays, they are using pulp sensibility. This is an important point. So if they give you options like you go for pulp sensibility or pulp vitality, although almost they are the same, they consider vitality as obsolete or historic name. So you'd go for pulp sensibility. Is this clear? Okay. Which bleaching agent provides maximum safety? Very important question. Sodium perborate. Sodium perborate is more easily controlled and safer than concentrated hydrogen peroxide solutions. Therefore, in most cases, it should be the material of choice in internal bleaching. Dislodged amalgam filling when the patient was having his breakfast. What is the reason? This picture, I think it was even in my exam, it has been repeated in the past or the whole past exams. So it was clearly in regards of secondary caries. There was a verbal abusive patient on front disc. What's the appropriate management? You remember this question? I asked you before this question, but with different frame. You have the right to refuse to treat a patient when he is directly or she is directly threatening you and may cause harm. This depends on the situation. A direct threat to you, right? So the patient is verbally abusive and on front desk just before you. So to tell a patient who is really verbally abusive that I will not treat you, I refuse to treat you, this is very irritating, and it may be a physical threat in this time, right? What early intervention strategies can de-escalate violence? Although many patients express anger, it usually resolves with respectful communication and very few patients react violently. Patients can sometimes become aggressive because they don't understand the system or why they cannot get what they want. Often understanding this and explaining makes a difference. If you are believe or if you believe you are not in immediate dangers, you may try to de-escalate the situation by appearing calm and remaining respectful, controlled, and confident. And this is really works, by the way, not from these evidence-based guidelines, even from my personal recommendation, it really works. Okay. A 14 and 15-old child with changes on front teeth, enamel hypoplasia. What is the most conservative treatment you recommend in that case? The patient wants to improve appearance. What is the most appropriate management? Microabrasion and restore with composite on the affected area only. A pregnant lady who realized 1 week before that she is pregnant and she there need for exodontia of mobile posterior tooth, which is suppurative, means it has pus and has pockets which are 4 mm, 6 mm deep. What do you manage or how do you manage the patient in this situation? Do the exodontia with local anesthesia for sure. You should never defer this case. Urgent dental treatment should not be deferred in these conditions. The tooth is suppurative with deep periodontal pockets indicating an active infection. Untreated dental infections during pregnancy pose risk of systemic complications like sepsis, threaten both maternal and fetus health. Prompt treatment is necessary to resolve the infection. A 4-year-old child requires a bite-wing radiograph. Which of the following is most appropriate advice to provide the parent when obtaining informed consent? Explain that the radiograph is necessary to diagnose hidden dental issues. Remember, there is what's called hidden decay. Anyone knows what's hidden decay? Hidden decay? Occult, yes, very good, Dr. Imelda. Occult caries. That's correct. Very good. Okay, I will just excuse you for a few minutes. I'll come back again. Thank you. Okay, a 4-year-old child with a documented nickel allergy presents with deep caries near the pulp in a primary molar requiring restoration. Which treatment option is most appropriate? Stainless steel. Why not stainless steel, guys? Because of the nickel allergy, because stainless steel is based on nickel, basically, right? We will have this final scenario. A 50-year-old female with poorly controlled diabetes. The HbA1c or 1c is 9. A smoker habit 2 cigarettes a day. History of periodontal bone loss on radiograph presents with gingival recession and a mesially over-contoured crown on tooth 4-6. Which clinical examination is most critical to definitively diagnose active periodontal disease? It should be periodontal probing to assess pocket depth and attachment loss. When using WHO periodontal probe to assess tooth 1-1, where should the clinical or the clinician position the fulcrum, the ring finger, for optimal stability and control? Resting on what? Resting on maxilla for sure, right? You can revise these pictures in Carranza. They are given in Carranza. I give some quotations from there. What is the position of the fulcrum ring finger to probe with WHO? It's the same as maxilla. You know, this quoted from Carranza, page 545. Can you see? Can you see the picture? There is some other site from which you can see different positions. Okay, we would stop at this point. Thank you for your interaction. Keep this hard work. I think many of you have done really great in the mock test. I would revise the question which was sent to me by some of you regarding the mock test. And keep this hard work. Thank you very much and God bless.